So again, kind of on the basis of talking about those definitions, that case, I want to talk now a bit more about dopamine, some of the neurophysiology, why we use these medications, so that we're on the same page about this class of medications and how they can be useful. And then I'll spend a little bit of time actually talking more about how we can do non-pharmacologic interventions as well as medication management. So this is a molecule of dopamine. Dopamine plays a huge role in our neurophysiology. In particular, has a lot to do with motivation. It's the reason why we like chocolate. It's the reason why we can pay attention and focus on things. We can become hyper-aroused and psychotic if this gets into excess. It plays into our motor system. It's why if we deplete this, people develop things like Parkinsonism, for example, with the extrapyramidal symptom. And again, dysregulation of dopamine can lead to certain medical problems, but from a palliative care standpoint can lead to particular symptoms. So in patients who receive chemotherapy, for example, elevated central nervous system amounts of dopamine can cause nausea and vomiting. And in delirium, this can lead to hallucinations. And dopamine antagonist medications, those that block dopamine receptors, can help to palliate symptoms of delirium and other symptoms such as nausea. In particular, if we think about the pathways, a lot of this has to do with elevated levels of dopamine, primarily in the midbrain and in the limbic cortex. And this is where our pleasure and reward centers, why we like chocolate, why we like pizza, why we like watching television or playing video games. But it's also the area of the brain where things like schizophrenia or other psychotic illnesses, or where we think delirium sort of plays into these dopaminergic pathways. Again, I mentioned, just kind of to highlight, in palliative care, we'll use some of these medicines, and you'll see in some of these discussions I have later on about how some of these drugs also target areas where we have emesis or the emetogenic centers in the area postrema. But oftentimes what we learn about, or what we worry about with medications or things that sort of block dopamine, is the nigrostriatal system, where we may get extrapyramidal symptoms like Parkinsonism, akathisia, dystonia, or drug-induced Parkinsonism. So the reason that we're talking about dopamine, and this, I'm sort of breaking some rules with doing PowerPoint slides, is that this is a really busy slide. This is an article from the American Journal of Psychiatry. But what this highlights is that there's lots of different reasons why people can develop delirium. It can be toxins, infection, acute inflammation, trauma, postoperative changes, decreased cardiac output, hypoxia, vitamin deficiencies, withdrawal syndromes, brain lesions. But part of the central process that we think is happening is that there's some neurotransmitter dysfunction. And I want to highlight with a big arrow that what we think is happening is that there's elevated levels of dopamine that relate to this. And thus, over time, we've developed, and there have been classes of medicines that in particular may help with delirium that were FDA approved here in the US for uses primarily around psychiatric illness. And so some classes of dopamine antagonists, particularly the first generation drugs, oftentimes referred to as typical agents, I have listed here, as well as some of the second generation or atypical agents. For those that are listening, you may notice I'm not using the word antipsychotic when I talk about these medications. I'm doing that primarily because the focus of how we use these medicines in palliative care is really around the neuroscience of what we're trying to target. So when we're using, say, for example, olanzapine or haloperidol for nausea, we're not trying to antipsychose symptoms, we're actually trying to help with nausea. And so our patients, and actually our colleagues, can get confused if we use the term antipsychotic, which I have really stopped using, and focus on the pharmacology of these agents, which is really that they're dopamine antagonists. And I'll talk more about that really as we kind of focus on the fact that these drugs aren't the same, they're different, and they have different affinities. And again, to kind of keep us all on the same page here, I wanted to talk just a little bit about receptor affinities for this class of medications. So the majority of these, as I mentioned, they're dopamine antagonists, and they block the D2 receptor, but they have lots of other receptors that they target. So serotonin receptors, histamine receptors, alpha-1 adrenergic receptors, acetylcholine muscarinic receptors. And so each of these medications can actually have very different effects. And so, for example, haloperidol, which we typically use oftentimes for patients with delirium, there's some controversy around this, is primarily a dopamine blocking agent. And so it has a high affinity at the D2 receptor and doesn't really target, like, say, serotonin, histamine, alpha-adrenergic, or acetylcholine receptors. If you compare that to a second generation agent like serochloroquetiapine, very little dopamine blocking activity, but a lot of antihistamine effect and alpha-adrenergic effect. And so why is this important? Well, the reason it's important is that the side effects or what these drugs do are different based on sort of what parts of the central nervous system they target. So we oftentimes think of the dopamine blocking part of this as the antipsychosis, or the part that helps with hallucinations, delusions, agitation. It's also the problem with these medications around the other Parkinson-like effects in the extrapyramidal system. Again, akathisia, acute dystonias, acute muscle contractions, the Parkinsonism, tremors, rigidity, and the long-term side effects like tardive dyskinesia. It's also what leads to some dry mouth or constipation with some of these agents. Postural hypotension, which can be problematic for some of these medications as well, so people having orthostasis and falls. But one of the reasons that we use it, and we don't talk about this oftentimes, is that a lot of these drugs have different variable effects on the antihistamine system, which is really where we oftentimes use this for symptom management, in addition to the dopaminergic function, which is it's sedating. And so certain drugs in this class can actually be more sedating than others and can be helpful to kind of harness that sedation side effect if we need it to help with some of the symptom management. Now, one thing that I talk with my team about a lot is, again, going back to this slide where there's, again, these like large variabilities in the way that these drugs target different receptors, is that they're not equivalent. They're not like opiates. You can't interchange them one-to-one because they don't just target one receptor system. And so if you try to think about equivalencies between any of these, it's really around how they target the dopamine receptor. And I've got two different slides here, one that kind of works more in whole numbers, and I'll sort of switch to that. And what it shows you is that like really low doses of medicines like risperidone and haloperidol are very potent at the D2 receptor, whereas things like thorazine, largactil, you require much higher dosages to get the same amount of dopamine blockade. And the point of this really isn't to sort of talk about the interchangeability, but it's to highlight the fact that they're not created equal, and they all have variable different side effects. And part of what I teach our team is really how to potentially use these medications a bit more in a sophisticated framework of harnessing some of the side effect profile, primarily the antihistaminergic effect or sedating effect, to help with symptoms. But again, all of this is sort of couched in the fact that these drugs have a lot of side effects. They, again, cause extrapyramidal side effects, metabolic effects. There can be cardiovascular toxicity, primarily QTc prolongation. But in our patient population, when people may be approaching the end of life, oftentimes a lot of what we're trying to figure out is that a lot of these risks are long-term. So a lot of these risks are related to treating psychiatric illnesses where somebody might be on a medication for schizophrenia for years or decades. And here we may be managing patients only for a few days or a few weeks. And so the risk-benefit profile and how we're sort of balancing that may be a little bit different. I do want to make a comment that here in the United States, that there is a black box warning or a warning that there is an increased risk of death associated with some of these medications, but it's specific to older patients, primarily with dementia-related psychoses that are treated with these in the long term, primarily in long-term care facilities or nursing homes. And the higher risk of death is oftentimes related to cardiovascular or cerebrovascular disease or stroke, as well as infection and pneumonia. So again, there's a lot of risk with some of these medications in the longer term, and in palliative care, and oftentimes we're taking patients with serious illness. It's harder to have this conversation with patients and families about the risks, particularly this risk of death. If you're using it in somebody with dementia, you really need to sort of take that into consideration. So I want to